Hello and welcome everyone. We're excited to have you at today's webinar, State of the Union, NGS Reimbursement. In today's session, you can expect to learn about the 2024 CPT codes, MolDX, the Medicare Gapfill process, and more. Please stick around until the end. We'll hold a Q&A session after the presentation. If you're interested in asking a question, please use the Zoom Q&A function. The button can be found at the bottom of the screen. Without further ado, I'll pass it off to my teammate, Sarah Overton.
Good day. Thank you all for joining us today to talk about the State of the Union for next generation sequencing reimbursement as of 2024. We appreciate you taking the time and are glad you're here. There's been a lot of changes in the last year, so it's great to have this touch base and highlight some of the key items that are really shifting in the landscape that's changing today. My name's Sarah Overton. I'm the Director of Revenue Cycle here at Velsera. I've worked in the diagnostic industry for about 15 years, really with a focus on next generation sequencing and oncology specifically, but really have worked throughout the time that MolDX has been created. I've really worked with them from the start and seen that shift and grow, and have focused on the revenue cycle management angle of all of the diagnostic industry changes over the years. Now, Velsera, you may know us as Purion. That's a previous name. Over the last year, we have changed and combined with Seven Bridges and Genentech to become Velsera. But Purion was our previous name. We still offer the same services and have expanded to include, a lot more with Genentech and Seven Bridges, but have maintained that same quality that Purion has been known for years. Really, to start, the three main items that I focus on that seem to be really critical to reimbursement and RCM in general, and having a successful financial program for molecular pathology really comes down to coverage, coding, and policy. There's a lot beneath that, but really that's a huge, start. Trying to obtain coverage for a test like this through items like dossiers, technical assessments. Those are becoming more and more frequent these days, and they're very critical to the success of programs. There's also coding. Coding is a shifting landscape. That is one of the main items we're going to talk about today, with brand new somatic CPT codes that have come out this year. And so coding is a critical element of the reimbursement environment and a successful program. And then policy downstream. Medical policies that the payers, consistently update and shift as new evidence is created, as the landscape changes and more tests are getting some of that coverage, and proving through things like dossiers and technical assessments. How they're enacted downstream through coverage and policy is very, very important. And really, why does this matter? Why is this so unique, I think, for molecular testing? I think there's been so much that's happened in the 15 years that I've been in this industry that we've seen shift and change. When I started, there was the old stack codes. The previous stack codes, if anyone's familiar with that, they were steps in a process like DNA lysis, DNA extraction. They didn't describe the test, they really described the action. And that was shifted to the new tier 1, tier 2 molecular codes over 10 years ago. And from there, MolDX was created. And since that time, because there's more accuracy, because there's more specificity for the codes themselves, we've really seen a lot of oversight and a lot of change as that continuum's evolved. So the current codes, we have tier 1 codes that are very specific, genes codes, tier 2 codes that are more general with analytes. And then we have the NOC code that is not specific at all. And there's different rigors beneath that. And what we've seen is with these new codes, there's been an explosion of multiple items. There's been a lot of fraud and abuse, especially over the last few years with COVID. We've seen there is a good amount of that as the codes came out, and there wasn't a lot of specific policy for some of them. So as a reaction to that, I think we've seen an increase in scrutiny on some of these tests. There really is a lack of federal oversight at this point. So a lot of the payers have taken on that action themselves, especially for the higher cost of test. And that makes sense because these are higher cost tests, and there's been an explosion in volume. So all of these things came together to create the environment we're in today, which is why I think it's shifting so much, because there has been so much that's occurred and the volume has just spiked so high. And these tests being higher cost in many cases, and cutting edge, there's new technologies, there's constantly new tests that are coming out that really are meeting a need that maybe has not been met before, but trying to get coverage and downstream get those into policy is part of the challenge that labs are experiencing today. Even well-established tests can still have challenges to meet the varying payer needs that are set out in the market today through things like technical assessments. So I wanted to start out with the CPT codes. That is a key element, again, of these type of tests. And for somatic, for next generation sequencing, for example, we have had a set of codes, really. We had 3 codes for many years that were just the normal 5 to 50 genes for hematomalignancies, 5 to 50 genes for solid tumor, and then 51 plus. And that has been the norm for many years. As of last year, there was 3 new codes that mirrored those old codes that were RNA specific. But since that time, we've had a new introduction of a brand new code. So these are the previous codes that came out. If you can see the 81445, that's the 5 to 50 gene solid tumor. These are the tried and true codes. And last year, when the new RNA codes came out, they just mirrored. The AMA obviously creates these codes, and then downstream payers will price them and create, hopefully, policies and coverage for them. And last year, with the introduction of the RNA-only codes, that was exactly what happened. They introduced new codes, and they mirrored the description of them, and they mirrored the crosswalked to the exact same reimbursement amount that was previous for the other 3 codes. Now, there was a new AMA, there was a new application last year to create more specific codes beyond just these 6 that were, in place in 2023. And if anyone sat or has looked through some of the calls or been a part of that process, there really was a lot of back and forth by the AMA as to what structure should be taken for these new codes. And ultimately, what occurred was 6 new codes were proposed and did come out from the AMA. 3 specific codes for cfDNA or plasma, and then 3 additional codes for solid tumor. And really, I think the point of these new codes is to be more specific. Just having the 5 to 50 genes and 51 plus didn't have a lot of details on what compromised that code, what was included as far as variant types, what was included as far as, there was no DNA only codes. There was DNA and or RNA, and then RNA. But now they're really trying to, I think, bridge the gap in what structure these panels actually take, because obviously there's levels of complexity, especially if you include items like TMB or MSI. So the cost is quite different. And I think the point is the AMA is trying to account for all of the different scenarios, which is great. The more specific, that's wonderful. I think the challenge was when these new codes came out, the 6 new codes came out, the previous gene count, the 5 to 50 genes in 51 plus, that was mirrored even again last year in the new codes that were created for RNA, was removed entirely from these new codes. So 6 new codes, 3 that are cfDNA specific, and no gene count for them. Hence, there's been some challenges from that standpoint from pricing these downstream through items like Medicare and CMS. So as you can see from the grid, there are different combinations of variant types. There's combinations of, is this solid organ? Is this DNA? Is this RNA? And they really do bridge the gap as far as they try, between this and the previous codes, trying to account for a lot of those different scenarios that you might have in an actual panel, but now half of them have gene counts and half of them don't. So it's an odd pairing. And ultimately, the AMA recommended that these codes be crosswalked to a higher amount for similar to the 51 plus. And CMS came back and said, no, they crosswalked them to the lower 5 to 50 gene amount. And then where we ended is with Gapfill. So that's where we are today. There's a lot of back and forth on these codes, and it's really just because the structure has been broken as far as what we've really seen them, developed in the past, the 5 to 50 genes and 51 plus. So that's where we are today. We're waiting for these codes to be gap filled. And again, the old codes still exist, and the new codes are in place. They're on the clinical lab fee schedule. They're just not priced on it yet because these have gone to gap fill. And the gap fill process is a unique process. That's one that takes some time to really try to account for the costs and different items that go into these tests when they're not being crosswalked, meaning crosswalked is you take another code and you say, this is similar to that, we'll use that same price. Gap fill is really a rigorous process that takes time. And ultimately, what the MACs are doing is they have asked for comments and they've asked for information from labs to start beginning to compile what these tests cost through MACs like Novitas and First Coast. MolDX has quite a few of the information already. They price individually through their DEX and Z code process today. But ultimately, all of the groups are set to develop that cost structure and take a look at that for all 6 new codes. On the screen, I've shown just typical, it's an example of how this flows for the gap fill process from a timing perspective. Ultimately, the codes are announced, and then once they are, in November, they're finalized to be put into place. And if they're gap filled, they generally will have the information. The MACs will report preliminary the amount for those new codes around April. So it does take a few months on their part. And then there's a public comment period where, just like an LCD, groups can comment on the gap filled amount. And then that's for 60 days. And then there may or may not be reconsideration requests. So the gap fill process really does take quite a bit of time. They'll report, they'll do in the first quarter, and then the second quarter, they'll post the prices around May or June for that 60-day comment. And hopefully there's no delay, but the final gap fill prices are posted by CMS typically around October. So until then, there is going to be a period of time where these codes are in place, but they are not quite priced because they are being gap filled. So that's an in-between time right now with the new codes that are so critical to many labs testing, specifically for next generation sequencing panels. Ultimately, what CMS will do is they will take a median of all of the MAC prices based on the count. So they're going to take into account each of the MAC's pricing structure. And then MolDX has the majority region across the country. And so the ultimate median will be heavily influenced by the MolDX amount that comes through. Usually FCSO, First Coast, and Novitas are frequently in lockstep, but not always. So really the outlier is National Government Services, but altogether they'll come up with the final median price. And then that leads us into, from the CPT codes, what happens next. So there's CPT codes created. Hopefully at some point they're priced. Hopefully the pricing is good. How does the coverage breakdown occur when we're talking about the policies and the different offerings, specifically for next generation sequencing? Really, there's quite a few MACs, but they break down into 3 general regions, which is really simple to kind of look at from an overview perspective. There's MolDX with 28 states, about 28 states and 7 jurisdictions. Then there is Novitas and First Coast that frequently, again, mirror each other as far as policy and articles. And then on their own is National Government Services. So trying to track policy from a Medicare perspective really takes into account these 3 regions. For next generation sequencing, there is an NCD, a national coverage determination, that is at a federal level. And really today that primarily is focused on FDA approved tests specific to next generation sequencing. But I believe it's important because oftentimes that NCD, which is 90.2, will filter down into the LCDs, into some of the requirements for the LCDs. But ultimately, all of the regions have specific LCDs on this type of testing, and then the national FDA approved NCD as well. And so this is the breakdown of the Medicare coverage for next generation sequencing. And for next generation sequencing, all of them today cover these codes. We don't know, the new codes are being priced, but as far as coverage, they all cover up to CGP today. There's one exception: National Government Services does not currently pay for hematomalignancies of above 51 genes, but for the most part, there's been a shift towards coverage for larger panels. So CGP tends to be codes that are greater than the 51 genes and frequently include more complex variants like TMB or MSI. So today, that's shifted quite a bit in the last couple of years. That was not the case. The 5 to 50 genes have been covered for quite some time, but now there's been a shift to more broad coverage. And then at the same time, we want to also consider MolDX coverage. So we've got the Medicare Max, which is very important to oncology testing, and specifically this type of test. It skews to a Medicare age in many cases. But then there's also MolDX, and it's not just Medicare anymore. So that map is really important. It is half the country, again, 28 states, fee-for-service Medicare is covered by MolDX, as you can see in blue. But additional to that, United Healthcare has begun requiring MolDX in the last few years. They have required it for, we'll go into more detail, but they've required it for Medicare Advantage for quite some time, and then it's expanding to commercial. But in addition to that, there's several other payers that also participate in the MolDX program to some extent. And that can vary from payer to payer when it comes to MolDX. But ultimately what this says is MolDX is national today. They are, not regional. It's regional for direct fee-for-service Medicare, but as far as the commercial payers that are involved, it is now at a national level. And that has shifted over the last few years because, this is a somewhat new requirement, which has been somewhat of a challenge for labs that are not in a previous MolDX fee-for-service region, because oftentimes the validations and different items were not necessarily done to the extent of a MolDX required technical assessment, which we'll go into. So what does the MolDX program actually look at, and what do they, what is the goal of what they're requiring and what they're doing? And again, if you think back to the shift from these stack codes to the new very specific tier 1 and tier 2 codes, once that began occurring, there was much more scrutiny on these tests that previously really hadn't even been able to be identified through the previous stack codes. So once that happened, pretty swiftly after that, the MolDX program was created and launched in around 2011. And originally it was just administered, it still is administered, but it was just applicable to Palmetto GBA, which is a specific Medicare MAC. And really they launched it to manage this new explosion of codes and molecular tests that previously really had not been identified. So they really start with 3 main items. They start with pricing, coding, and coverage. Very, very similar to what we look at from an overall perspective from RCM. And they have a very, very unique capability to do that as a payer, because of their requirements, because of what they've done with their Z-code, DEX site, and technical assessment process. They really have a lot of capability to upfront do a very deep dive into the test and understanding it, pricing it, and setting it up versus, going at a claim level downstream like many other payers do today. But those are the three main focus of the MolDX program for molecular diagnostic testing. Not all testing, a lot of it can go through, but there are very specific requirements based on what type of test you have. So, it's very different for a single PCR gene test than it is for a next generation sequencing 500 gene test. At the same time, there are paths to coverage, even for novel and proprietary tests, but they are a longer path and require more rigorous data and more specific items to really even attempt to get coverage for new tests. Regarding the transition from United Healthcare to MolDX, that has occurred in waves. The requirement began nationally for United Healthcare effective 4/1/2022. So at a Medicare Advantage level. And I believe that was a lot easier to implement because it was really mirroring the current program. MolDX already was specific to Medicare, so mirroring a Medicare Advantage program was a smoother transition than I believe the commercial transition will be, because so much of it applies. It's taking, Medicare Advantage and really putting that through the system that's already used for Medicare. But they've also, so since that time, MolDX has announced that they're transitioning to their commercial, full commercial requirements for technical assessments and Z codes. That's been shifted a few times. It was originally meant to be in effect about August of 2023. It shifted again, and now it's come back effective April Fool's Day. So 4/1/2024 is the timeline. And a lot of that, I believe, is to allow for these labs the time to prepare for that requirement, because so many did not already meet that in the validation standards they had set. And MolDX is very specific in their requirements. So the updated policy is out. And as of April 1st, they're shifting away from the genetic test registry that they previously used with unique ID to the DEX Z code requirement. And it's really very, I think, confusing to know what is required for United as far as the MolDX program. Is it just the Z code? Is it a technical assessment? Is it both? There's really, I think it's been unclear from a lot of what I've seen in the press releases and the different information out there. But I've reached out to both the MolDX program and United, and it seems clear that they are requiring technical assessments in some cases. Now, with every commercial payer, MolDX will say themselves that it is up to the payer to implement how they utilize the MolDX program, meaning that not all of them will require technical assessments. Not all of them will use the system in the same way. Some of them may just use the Z codes. Some of them may use technical assessments. There may be a combination. It is at their discretion how they utilize the program. And I think that's really important. If you've got different payers in your region that are volume that you want to make sure you are accounting for, I would really suggest understanding the requirements at a payer level, because they are not all the same. And just having a Z code without a technical assessment, if that's a requirement for certain tests, it is going to result in denials. So it's really important to understand how each operates if any of the payers affect you. For United, it's clear for Medicare Advantage, and in a lot of cases, they're requiring a technical assessment. And for commercial, it sounds like that will be the case as well. And what they've really conveyed is that for more complex testing, it will be required, the technical assessment, the full item. So it's not just the Z code. If there's small, single PCR, again, gene tests, those may not require a full tech assessment, but something like next generation sequencing panels absolutely will. So expect that those are going to be a requirement. And, it is quite a different process going through technical assessment when you have not been in a MolDX state previously. So it's a shift. But Medicare coverage has expanded really in the last couple of years. You're seeing MolDX expand. You're seeing CGP coverage expand. It's really a lot of this has grown with some of the different elements we talked about, the explosion of volume, the explosion of fraud. There's been quite a bit of scrutiny over the last few years. But as I mentioned, MolDX first covered CGP via their technical assessment process. It wasn't a given, but they did have the opportunity to cover CGP previously. Then over the last few years, both National Government Services in 2022 and now in the new LCD for Novitas and First Coast, both now include 81455 and the 51 plus genes on their billing and coding articles as well. So we've really again seen a shift towards coverage just even in the last 2 years, and I don't think that that's a surprise that we've also seen an increase in scrutiny by items payers like MolDX that want to get their arms around this and control these type of tests through MolDX. It kind of goes hand in hand. So there's many different LCDs and billing and coding articles throughout the MolDX program. They mirror each other, as far as these targeted panel and CGP coverage. They all have their own billing and coding articles and LCDs, but they really are in lockstep for the most part. They're different numbers. They may even have different effective dates, but they really all mirror each other and have been in place for some time. As that's the case, those directly correlate to your technical assessment if you're going to be submitting for that. They really go hand in hand with the intended use, the patient population. It's really important to understand the LCD and the billing and coding articles for CGP, for next generation sequencing, when considering your technical assessment, your validation, how you're planning to move that forward. One of the most critical items is your intended use and defining what patient population you believe that the technical assessment, the test is going to serve, and then ultimately defining that clinical utility. So when it comes to that, there's 3 items, in addition to clinical utility, there's also clinical validity and analytical validity that MolDX really focuses on when they're looking at their technical assessment, from their requirements, from what they ask for, and then obviously what they're going to look at. Those 3 items are really critical. And they're all important, but if you don't have clinical utility, it's all moot. You could have wonderful clinical, CV and AV data, and if there's not utility to support the test, it will not move forward with coverage. So I'd really say, keeping in mind that all 3 are important, and there's different thresholds for that you're going to want to try to meet, but each is important in their own way. And then the absolute is you need to have clinical utility to define the patient population of your test. And as far as, what MolDX requires for a technical assessment, they have multiple items that are needed, to submit to begin consideration for tests like this. And ultimately, they're in a very unique position because they can look so specifically into these tests that it's not an all or nothing. It is not, it's covered or it's not. There's an in-between. There's full coverage, there's, denial, or where they, MolDX will write back and cite questions or deficiencies. And then there's a middle ground where they can even price at a variant level, meaning, if you've submitted for a technical assessment that has multiple variant types, and say you don't have enough TMB samples from a clinical validity standpoint for them to feel confident in coverage, they will still potentially price the test and cover it, but they will not pay for TMB. They can, specifically remove that amount. So it's very unique the way they're able to price their tests, because they have what's called a Z code that really almost trumps the CPT code. CPT code is a lot less important for MolDX because they go in and they have a specific Z code that's assigned that drives your pricing and coverage. So if that's the case, they can really be very unique in how they structure the pricing. And that could be for multiple reasons that they don't price a certain variant type or certain section. Could be that there are not enough clinical samples. It could be that there might not be enough literature to support it in certain disease states. It could be that the numbers, the sensitivity or specificity are not good for those. So there's multiple reasons, but ultimately a test can receive coverage, but just not full coverage by MolDX. And in that dossier, really, MolDX requires quite a bit of information. They have their own worksheets that we're going to talk through as well. But they have a requirement for a dossier that needs to include your entire validation. Your validation needs to be submitted for larger, more complex assays like this. So that is going to be required. And then they have specifics that they want in addition to that. So I call that the dossier. So it's a separate document that's going to have items like your test requisition form, a sample report to show how, a test report would actually look for the test that you're asking for coverage. There's items that are really helpful to include on the dossier as well, like the formulas and definitions, used for calculations. It's very, very helpful to streamline those to avoid confusion. And even detailed information on the orthogonal test and method used for the clinical validation. I find that very helpful to avoid any confusion. Having as much information in your dossier to support your submission, in addition to what's required in the worksheets and the validation, is helpful to expedite the submission process and ultimately to receive coverage. And shifting on from MolDX, we've also got 2 other regions that cover a large part of the country. And that is, again, Novitas and First Coast, that are very similar in their LCDs and articles. This has been through a journey. There is a proposed genetic testing for oncology LCD that has been through quite a few iterations over the last few years. But ultimately, what's in place today is there are billing and coding articles that are broad, that are molecular pathology and genetic testing that is in place for both regions. But they're expanding to include more specifics on the genetic testing for oncology. Originally, this LCD was put out. It had quite a bit of comments in both regions. And from the time that the original article was, and LCD was actually submitted to the final version, it's quite a few changes. If anybody has been following that, that's almost an understatement. There was a lot of changes when it was the final LCD was put in place. And so ultimately that was rescinded and then was put back out for comments, which has been done for many months now. And we've been really in limbo as far as the final version of the LCD. But that will be very helpful once that is published. And that this really takes two regions that were not highly defined as far as molecular testing, other than this billing and coding article doesn't have a lot of information on diagnosis codes, doesn't have a lot of specifics. Has been, rampant for fraud and abuse during the last few years, and it's going to be very, very specific when these new LCDs and articles are in place. And really, what they propose beyond, now including the 51 plus CGP CPT code, there's criteria for next generation sequencing that are being put into place. So they have, there's a lot more rigor in what they're going to be looking at. And there has to be some sort of interpretation, some evidence that's been put in place for all of that. And they're cited has to be one of the following. They cite ClinGen, NCCN, OncoKB, but it's really clear that the reporting side is important to this LCD, and that there's going to be requirements for actually defining where the information is coming from. Additionally, I thought it was very interesting, the LCD cites that there will be post-payment audits. They talk about how important the validation is. So these MACs have not moved to MolDX, but it's clear that they're all starting to shift more towards requirements for validation. And those post-payment audits, they don't define a lot today, but that will be interesting to see what they do require if they do request, the full validation or what specific information they're looking for beyond just meeting this evidence requirement that they've defined in the actual LCD itself. And then national government services, I mentioned that they shifted towards requirements or coverage for CGP over the last few years. And really, that's been great because they had no coverage for above 51 genes until 4/1/22. And that expanded to now be quite a robust approval with over 600 ICD-10 codes. And they really came out in strong support of this type of testing. And there's quite a great amount of detail that was included in the LCD to support coverage. So we've really, again, seen a shift from, this is for solid tumor, by the way, specifically. Again, I mentioned that hematologic malignancies still are not covered, but this is a strong shift in the right direction for coverage across all regions now. At the same time, we also have a lot of movement with state legislation for biomarkers. There's been a flurry of activity with different states that have enacted very similar laws over the last few years, specific to biomarker coverage and in many cases, cancer specifically. These are challenging. It's great to see the momentum for states to step in and help to guide this type of critical care and access for patients to this really important type of testing, but they're not always well defined. And the less defined things are, the more payers tend to, have ways to evade them. But what has happened is in many of the states, some Medicaids have begun covering these type of tests at some level. There's state-funded, programs that have, begun to pay for this type of testing. So there's definitely a good shift in the right direction, but not all payers are going to abide by these biomarker coverage laws that have been put in place. And I believe this will expand. It was just a handful a few years ago, and now, we've seen, I think, 14, and then there's more bills proposed in new states that will likely mirror these quite a bit as well. And the effective dates kind of are spread out. The most recent, New York and Minnesota were approved, and New York has some really unique specific items in it that I'm excited to see how those ultimately are put into effect next year when it takes effect in 2025. And we talked about a lot of the coverage and the policies that apply to this type of testing. But downstream, from that, we see a lot of challenges with commercial payers and how they actually enact that coverage and policy. So for this type of testing, we'll see a lot of denials for not medically necessary and experimental and investigational. Those are the two big ones. There's also, it's a critical element to have prior authorizations, a really, really good solution for prior authorizations put in place before launching this type of test, because so many commercial payers require prior authorization at this point. And it's very difficult to have a successful program without a steady process for prior authorization. A lot of these tests are considered genetic testing and automatically go to the bucket that prior authorization is required. Even, for this test, that their standard of care in a lot of cases, these are very typical tests, and CGP today from commercial payers is limited often in the coverage policies for larger groups paying above 51 genes. Now, with the addition of these brand new CPT codes, I'm really interested to see how this will all flow, where the genes have kind of been removed from the equation for half of them, which is weird, but it's the case. So, in the past, there's been so much scrutiny around that line of 51 genes, 50 genes, and now that's really been removed. So there's likely going to be a very big shift in coverage and payment for these, but we're just starting to see that as the codes just came out. But really that line is gone because for many years, there's a lot of payers that pay for the 5 to 50 genes in specific disease states or for specific ICD-10s. And then again, now that's really been kind of removed. So this will be very interesting to see not only how these tests are gap filled, how they're priced, but again, that critical element of how are they actually enacted into policy and how they're covered. So I believe these will still remain the main denials for this type of testing, but the rigor in how they define what that coverage standard is when it's not based on genes is going to be really unique to see. And we talked about some of the challenges in the industry for revenue cycle for next generation sequencing. Now I want to talk a little bit about some of the services that Velsera offers to clients that are specific to the type of challenges that really try to help guide labs through some of these really very critical items for their lab. We have revenue cycle management services that we offer in addition to really critical items for success like validation services. The heart of any good technical assessment is your validation. It is absolutely critical. There's no way to be successful for a technical assessment unless the design and actual, how the validation was performed is done in a very specific way that meets the standards of MolDX. They're very specific items like for clinical validity, MolDX for next generation sequencing wants to see 59 samples at a minimum. And beneath that, they're going to want to see not only 59, they're going to want to see a healthy amount of variety for each variant type. And that's not always the case. That's not necessarily the validation design in non-MolDX regions. It's not needed for CLIA or CAP. So, just in your design itself, that's just a critical element. So Velsera also offers validation services that go hand in hand with the technical assessment process. But really, we're helping clients launch not from just a clinical perspective or reporting, which Kieran and Velsera have focused on, but through that validation, which is very highly complex for CGP, down through how do you prepare to actually launch the program as far as return on investment and focusing on how to be successful financially. Clinical is the most important. It needs to make sense clinically for patients for each lab, but ultimately it can only be successful and be maintained long term if there is a return on investment. And striking that balance is really tough. So I think, the design phase of any NGS launch is really, really important, and how you set yourself up for success. And so that's what we really help to do, whether it's a brand new launch and a client's not familiar with next generation sequencing at all, or has struggled and, are trying to get technical assessment coverage and have already launched or are not, seeing a return on investment. We see multiple clients in different states, but it's really meant to take a look at that program and help align the financials with the clinical. So we always look at that Medicare MAC analysis. That's the first step, is which MAC is your lab physically in, that the testing is being billed to, because they're very different, your requirements for each, in a sense. Now with United Healthcare, really, it's MolDX is national. So it's gone are the days of only your MAC, is what you need to go by as far as Medicare. Because for Medicare Advantage, United's requiring that, and soon it's going to shift towards commercial. But still, if you're in a non-MolDX state, fee-for-service Medicare, you're going to need to know both, because you have two different requirement sets. So ultimately, just doing a payer mix analysis of not only Medicare, understanding MolDX, and then your top payers, say what do they cover, what do they require, is really important. Again, defining that prior authorization workflow. And, if clients haven't been able to do that themselves, there's great partners out there like CareViso and several that really have done an amazing job of meeting the needs of clients for prior authorization. But there are, it has to be done. It's just a critical element of the program to make it successful, is having something in place for those commercial payers that require prior authorization. Also, we help create appeals that are very custom for this type of test, it's very unique, it's very specific. So we'll create levels of appeals and prior authorization templates by assay, and then look at your ICD-10 and your CLFS CPT coding options. Gone are the days where there's a one-to-one, as far as, it was pretty clear before with 5 to 50 genes and 51 plus, and now there's more options here that have kind of expanded this year. All of these things are really important, even down to your IT integration, your pricing review. Are you going to create subpanels for a test if you have a larger assay? Because again, not all payers do still cover the larger panels. So there's a lot of items to consider. And then from there, it's really important to design your tech assessment to match and to be able to have that flow through, like with subpanels. There's a very specific way you would create your technical assessment for subpanels. And for the actual MolDX side, we work with our clients to create the package with them. All of the wet work, all of the work is being done on their end. We are just stepping in to help create the actual requirements that we already went through. So it's quite rigorous, but the clients are doing all of the work themselves, and we're helping to coordinate that into a submission based on our experience with MolDX and their requirements. Again, it's quite extensive with the worksheets, sample level data, and all of the dossier requirements, but it's absolutely something that we help to create with our clients along with that validation. And ultimately, I mentioned that, Velsera offers not only RCM services, but we also have validation services. And ultimately, we have our flagship product, which is CGW, and that is a reporting solution. But again, you're even seeing in the new Novitas First Coast how much scrutiny they are putting on the reporting side, the knowledge-based side of this type of test. There's only going to be more scrutiny on not only the validation itself, revenue cycle, but also reporting. So really, our team here at Velsera works hand in hand across all 3 items to support you to success on the other side of it. So I believe that, all 3 items are critical, and really a really large part of success is that they need to be integrated. Having a completely separate validation from your technical assessment is challenging. They need to flow, they need to say the exact same thing, and your likelihood of success is a lot higher if you've done them together and you've really done that with the design in mind for MolDX. Okay. And that is all for the presentation. I think we are ready for questions if we have them.
Sarah, thank you so much for an insightful presentation. There have been multiple questions submitted in the Q&A, and if anyone out there still hasn't submitted a question, it's not too late. Please use the Q&A function to submit a question. We may not have enough time for everyone's questions, but if we miss yours, our team will do their best to follow up with you after the session. Let's dive in. Sarah, how do you think the Gapfill pricing will be handled for the new GSP codes?
That's a good question. I think that the new GSP codes are going to vary quite a bit because of the level of complexity that we've seen within them. Some have items like TMB included. So in that case, oftentimes TMB, you need a minimum of 200 to 300 genes, which has a different cost structure potentially. It may be something that's a little less complex that doesn't include TMB and maybe doesn't have CNVs. So I think that there's going to need to be a bit of scrutiny around not only the specimen type. So for cfDNA plasma, there tends to be, even with the AMA, when they price those, they price them at a higher rate. They suggested for CMS a slight increase because of the level of complexity of that test. So I think we're going to see a bit of variance. And I think that was the point that there are different requirements for levels of complexity based on what's included in your test, but how each MAC's going to account for that is going to be interesting. MolDX has so much of that information already, having gone through, rigorous process to price by variant type. And again, they're the vast majority of, the median, because they're more than half the country. So I think they're going to influence quite a bit that pricing, but ultimately, I think we're going to see a variety there, not only from MAC to MAC, but hopefully from code to code, because that was really the intent of them to begin with.
Okay, thank you. This next one is a two-part question. If DNA and RNA NGS panels are from two vendors, would you bill the two of the same or different CPT codes, assuming the gene numbers are similar? That's the first part.
Trying to think of how that would flow. On the same specimen source?
Well, and it continues to, if one patient gets both a DNA test and an RNA test, would CMS reimburse both or only one test?
The data service is going to be a really big point there as far as how those are run. I don't know why you would split a test or if they would run in tandem. Trying to think. In theory, if like a DNA test was run alone and then for some reason at another point the RNA was run on a different date by the same lab or a different lab, in theory, according to the date of service rule for Medicare, I believe there could be separate submissions for that technically, but I would have to understand why they were being done separate, kind of in a reflex fashion, if there was a rhyme or reason to that. But technically, potentially, I'm trying to think of a situation where DNA and RNA would split for the same date of service and why that would occur. But again, potentially. And again, trying to untie these from an inpatient encounter, if it was an outpatient or non-hospital patient, potentially.
Okay. Next question is, I'm sorry, it skipped. What happens with tests we send out to other laboratories when the other laboratory doesn't do any billing except to their own clients? How do we get the DEX codes for those?
If you are sending a test out to another laboratory in a full, there's a distributed model and then there's sending out, right? So there's two different items to consider. There's a lot of distributed model options out there. If anybody's familiar with the CAP distributed model, where potentially the wet lab and the dry lab are split somewhat, reporting bioinformatics on one end, that happens all the time. That's quite common, especially when it costs so much to run the wet lab portion of that. And we've actually worked on submissions to MolDX and been successful on obtaining distributed model, setup for labs. But if it's a complete send out, if it's not FDA approved, number one, you would need to have all the information needed to submit a technical assessment, which is rigorous. And I don't know, you have to look in from a compliance perspective what you can bill as far as if you're sending it completely out. There's the 60/40 rule for Medicare as to what you can or can't bill if you're not doing all of the work. So there's a lot that would go into that beyond just getting the Z code and being able to bill for it. But if you had additional tests that were already being done 100% by your lab and you could meet some of those standards, the biggest challenge, even if you could bill it directly, from another lab that's not choosing to bill themselves because it's client bill scenario, you would have to be able to work with them to get all of the information to be able to submit on their behalf, essentially, as an intermediary. And that's really challenging. Even for a distributed model, that can be challenging. That's the biggest challenge with either structure, because your lab only owns part or none of it, as far as gathering. That information is hard to obtain, define, combine to begin with. So put it in the hands of a different lab, that considers a lot of that proprietary. Validation is extremely proprietary to many labs. So there's challenges when you don't own the entirety of the process. It's absolutely doable. Like I said, we've done it, but there are challenges to doing that. And really, the one thing I do want to define about that, if you are doing a distributive model, what's clear is you can't take, the validation of the other lab and say, okay, here's this, we're going to submit this. If you're doing part of the work, it's really critical for any submission that you have to consider that what you submit in your tech assessment, those 59 at a minimum clinical samples, you have to make sure that the process that you're submitting is the way, actually what you'll be reporting on is what you submit to MolDX, meaning that, if you're splitting it wet lab, dry lab, that all 59 samples at a minimum have done that, where it's not just, you've taken the wet lab work done at one lab A and then the reporting and bioinformatics lab B, combine them, and that's in your submission. If they have their own validation, there's elements of that are important, but ultimately what you're submitting as far as the CV data needs to be the combined work, if that makes sense. You'd have different elements. You'd have, the validation from A and B, and then the combined work of the clinical samples for both that you would need to submit in the technical assessment. So it's challenging. It's a lot of moving parts, but it's absolutely doable.
Thank you. Next question is, could you differentiate between ICD-10, CPT, and DEX-Z codes for the layman?
Yes, absolutely. And my apologies if I did not go into those in more detail. It's acronym soup out here too, with all of the when I hear myself speak and I'm like, the CAP-CLIA FDA approved DEX system through the IC, it's a lot of words. But ultimately, ICD-10s are diagnosis codes. So those are codes that support the test being run. So if you were to suspect cancer for a patient and order, a test, there's direct ICD-10 codes, diagnosis codes that you would choose to most accurately describe what you're looking for. So you choose that to say, I'm running this because this is the diagnosis I believe the patient has, or the patient does have a diagnosis. They've been diagnosed with breast cancer, and you're running a somatic test to sequence that cancer. So that it's really supporting. Those are very important, though, because at the end of the day, not all diagnoses are covered for certain indications. So there could be a cancer that is not covered right now. There isn't a lot of literature to support coverage for sequencing for a specific cancer. So the diagnosis codes really support your medical necessity. A CPT code is just a way to describe the test. It's a billing term used to describe the test that's being run. And they're very, very challenging to keep up with due to innovation, due to differences in tests, due to so many different items. It's hard to describe so many tests and keep up with innovation through the AMA CPT codes. There's a process for PLA codes, proprietary lab analysis codes, that are either sole source from one lab or FDA approved, that have expanded that a little bit and made the process somewhat easier. But ultimately, the CPT code is just a way, as close as you can, to describing the test that's being performed in terms defined by the AMA through their CPT code process. The DEX code is a separate code that really goes one level deeper than the CPT, because they're accounting for each unique test, each variant type that's underneath it, and then coverage of that. So it's one more layer down. And it's really at this point only required by MolDX and what other payers are following MolDX at this point. So it's almost like a very specific modifier that's being added to your test that has coverage, pricing, and everything attached to it on the other side in the MolDX system. So those are really three completely separate ways that payers are helping to identify, pay for, and cover these type of molecular tests.
Okay, thank you so much, Sarah. Well, it looks like we're just about at time. We can definitely follow up on these extra questions that we have with one-on-one sessions. We will be contacting you in the next few days. Thank you so much for your participation, and we look forward to seeing you again.
Yeah, thanks for joining us today.